You have to know the 3 phases of healing. What I'm getting ready to share with you is a little overboard, but you need to be familiar. And then I'm going to go into the bare minimums. What is the bare minimum you need to know relative to the... Because remember, your therapeutic protocol, a major component of your therapeutic protocol, is dependent on what phase of healing they're in. As a matter of fact, that is the only thing that will determine if the person has MMI with a permanent impairment. It's totally based on the 3 phases of healing. So, having said that, let's cover some of the minutiae. So this will get a little deeper than we like, and then let me come back and simplify it, okay? So that's how we're going to look at this. So, 3 phases of healing basics. The inflammation phase, 72 hours after an injury. Remember, that's if there's no further irritant. Is that reality? No, it's not reality. So, during this phase, damaged dead cells are cleared out along with the bacteria and other pathogens or debris. This happens through the process of phagocytosis, where the white blood cells eat debris by engulfing it. Platelet-derived growth factors are released into the wound that cause the migration and division of cells during the proliferative phase. Inflammation. Repair phase. The repair is anywhere from 6 to 12 weeks. Remember I said that's just the bell curve. You could find some statistics where it was maybe 3 to 4 weeks. You could find maybe 14 to 16. I'm talking to... And it's for ease of explanation. It's like the bell curve of the repair, and it's for ease of explanation. That's what this is. It's not going to be at 6 weeks, then the collagen starts. Do you understand this? Okay. In this phase, angiogenesis, collagen deposition, granular tissue formation, epithelialization, and wound contraction occur. In angiogenesis, vascular endothelial cells form new blood vessels. Fibroplasia and granulation tissue formation, fibroblasts grow in a new form, provisional extracellular matrix by excreting collagen and fibronectin. That's very important right there. That's type 3 collagen right there. Concurrently, reepithelialization of the epidermis occurs, in which epithelial cells proliferate and crawl atop the wound bed, providing cover for the new tissue. Repair or the proliferative phase from 6 to 12 weeks after an injury. So you have the wound contraction. Myofibroblasts decrease the size of the wound by gripping the wound edges and contracting using a mechanism that resembles that in smooth muscle cells. When the cells rows are close to complete, unneeded cells undergo cell death. Repair or proliferant phase. So this is what is very important to know. So I'm going to simplify it right now. This is what you need to know. This is like simple 101, okay? This is unbelievably important that you know this and are able to explain this. So we talked about the 3 phases of healing and the time periods. You need to know that. Inflammation phase, pretty easy. Pain and inflammation. Remodel phase, okay? What is so important about all these phases is the repair phase. And I'd say the repair phase is unbelievably the most important of the 3 phases for these reasons. Number 1, you have hyperinnervation, reinnervation. So anytime there's inflammation, damage to tissue, the peripheral nerves regenerate and go in there. Well, they go in an increased number. Now, what I'm sharing with you is also how I explain it to a jury. So you need to know, what does this mean relative to a patient and a jury, okay? So, when there's an increased number, so let me go through all of them and then I'll go into each one individually, that you need to know the basic explanation, because this is how you're going to explain it in a narrative report or to a jury or in a deposition, okay? And this is why people have permanent chronic problems and they need prognosis and the need for care, and it's ongoing. So here we go. You have hyperinnervation, reinnervation, increased number of regenerative peripheral nerves in the damaged tissue, number 1. Number 2, the nerves fire at a lower threshold. Number 3, those nerves get tangled in the collagen matrix. Okay, those are 3 key neurological components. 3. Now there's 2 connective tissue components. When you have that tissue, remember, there's cellular regeneration, collagen formation. Collagen's a protein. There's all types of collagen. the neuromusculoskeletal component is basically composed of what's type 1 collagen. The injured tissue is formed type 3 collagen. What's the difference between type 3 collagen and type 1 that you were born with? Type 3 is only 75% as strong, and it's only 75% as elastic. Now, what does this mean to the patient? Okay, so let's go through each one of these. What is this? What's the relativeness? First of all, when you have an injury, how many cells does it take when you have an injury for the 3 phases of healing to kick in? 1. Your body heals naturally with 1 cell, death, doesn't it? Okay? So here's the key with you as chiropractors and doctors. The key is quantity or quality of cells that are damaged or injured. That's the key. Quality and quantity. Here's an example. Let's say I have 100 cells in my quadriceps muscle. How big my quadriceps muscle is. I have 100 cells damaged. Whack. Is it going to make much difference in the function of my quadriceps? It's not going to make any difference. Okay? It's called subthreshold. Subthreshold. It's not going to be relevant. It's not going to be relevant to personal injury because I'm not going to lose any functional capacity. Now, I have 100 cones in my retina of my eye damaged. How's that going to affect me? Way more, right? On a percentage basis. They're both 100 cells, but the 100 cells in the eye, the quality relative to that is way more important than 100 cells of muscle. So we're going to pay attention to quality and quantity of the injury, and that's going to determine whether it's subthreshold or threshold or an extreme injury. And I'll go into that in a second. It's called 3 degrees of an injury. But here's what we want to know now. Number 1, when there's hyper-regeneration of the peripheral nerves after an injury, because when does any of this happen? After there's any injury, the 3 phases healing always happen. Always. 1 cell, 2 cells, 10 cells. That's the way it goes. Your job is to document that. The more sensitive your documentation is, the more likely you're going to pick it up. You don't do sensitivity testing, you're not going to pick it up unless it's gross. So, if you have increased number of nerves in that area, just because there's an increased number in the same area, when the patient does activities of daily living, bending, twisting, turning, sleeping, cooking, showering, in other words, they live life, they move dynamically, right? When this happens, because there's an increased number of nerves in the same confined area, are you more likely, less likely, or about the same to feel pain? More likely. Why? There's just an increase in the number of nerves in the same confined area with the same motion. Does that make sense? You need to be able to explain that. You need to be able to explain that to a jury. Number 2, the nerves that regenerate are more sensitive. You guys know this. You hurt yourself, you touch it, and it's painful quicker, right? Now, what does that mean to the patient? If those nerves heal with a fire at a lower threshold, what does that mean to the patient? Well, when the patient does typically active range of motion, they typically won't have any trouble. But when they go into overpressure motion, in other words, the more they stress that tissue, okay, the more likely I'm going to compress that nerve and fire it. So what does it mean to the patient? It means that nerve's going to fire when I could do things like, let's say, bend over, and I could bend over and pick up laundry. Now when I bend over, I can't. When I go into overpressure, I can't. Why? Because the nerves are firing quicker. So you have lower threshold, so the activity that you normally could do at 100% with no firing, now when you try to do it 100% will fire because of the low threshold of the nerves. You guys know that. You injure yourself, it's a little more sensitive, so what do? You don't move it as much. Okay? Makes sense, right? This is how I explain it to a jury. Number 3, now we're mixing the nerves with the collagen. So the collagen is synthesized. It's only synthesized when? Only in the second phase. Is collagen synthesized in the inflammatory phase? No. Is it synthesized in the remodel phase? No. Collagen is synthesized in the repair phase of healing. That's why it's called repair. So when you have collagen, now what's the big deal with this collagen? You got 3 big deals. It's type 3 collagen, not type 1 that you're born with. What does that mean? Number 1, the collagen goes in there in a matrix formation. It just randomly goes in. It just randomly lays down. What does that mean to the patient? Well, when that matrix goes in randomly, and those increased number of peripheral nerves get trapped in the matrix. So we have an increased number of nerves. Does the likelihood of those nerve trappings go up or down if you have an increase in the number of nerves? Goes up. So now you have this matrix. So you have these nerves that are increased that are now in the matrix. So now you move. So what happens when you move? It contracts. So now you have these peripheral nerves that are in the matrix more than normal. So is the patient more likely to have pain or less likely? More likely. That's what happens first. The next thing that happens is those nerves will fire quicker. Why will they fire quicker when the patient moves? It's lower threshold. So you have more nerves, lower threshold. So it moves. So it's going to compress them and start to pain more because increased nerves. And because it's a lower threshold, it's going to fire quicker. That's why you'll have pain that'll get you to stop doing an activity of daily living. You'll modify your behavior, or you won't do that, or you'll stop going into overpressure, okay? All right. What's the next category that happens? And this is what you need to be able to explain. You need to know. So what's the next category that happens? The elasticity, the collagen is only 75% as strong. Now, is it 74%? Is it 72%? I don't care. It's the bell curve of strength. So could you find some articles in Science that might say the collagen is 68%? Maybe. Can you find some that says it's 82%? Maybe. What's my point? I'm using the bell curve of probability for ease of explanation and high probability. Do you understand this? Okay? Because I had doctors say that. Well, doctor, here it says it's only 62%. I get whack jobs like this. I'm like, this is the big picture to explain it to a jury or to an attorney. So you have to dumb this down to a jury, okay? Okay, so if it's only 75% as strong, and by the way, why is it only 75% as strong? Here's why. You have this matrix. You have all these collagen fibers in different directions, right? So, this is a great analogy. I would remember this or write this down in a deposition or in court. That if you have, as an example, let's say I have 10 pieces of string. And I take those 10 pieces of string and I lay them all randomly in a circle. One here, one here, one here. In other words, a matrix. And then I go and pull on any directions of those strings. There's a certain amount of force I can pull before those strings will break. Okay? Now, let's take all of those strings that are laid in this way, and let's align them up, all in this direction right here. So now I got all the strings in this direction. Let's apply the same force. Is it going to break now? No. Now we have huge tensile strength. Now in bone, you know that as what? What? The matrix of bone. You physically see that, especially in the femur, right? You take an x-ray of the femur, you can see that matrix, the density of that matrix of that bone, of those stress lines with absolute clarity, can't you? That's the exact same thing that's happening to the soft tissue. So, when the matrix is spread out like that, it takes a certain amount of tissue. That's why it's weaker, because it's spread out. Well, that's the opposite. When you do the chiropractic adjustment, that's actually what it's doing. It's helping to align the matrix, and that's what helps make the tissue stronger. So that's what makes it weaker. Now, it's not as elastic because it's type 3 collagen. So what does that mean to the patient? So first of all, the strength part. What does that mean to the patient when it's not as strong? They'll go and do a normal activity that they could do fully before the injury. Now they go and do that activity, and what happens? Re-exacerbation, because they can't do it fully. So they have micro lesions, and that's called a re-exacerbation. That's why. Next, elasticity. The type 3 collagen is only 75% is elastic, right? What does that mean to the patient? It means the patient is going to have restrictions. Now, in a common one in chiropractic and personal injury, a very common one, is after a person has been in an auto accident with the neck, very often they can no longer turn their neck when they go to back out. They now have to look in the rearview mirror. What range of motion will become restricted first? Active, passive without overpressure, or joint motion? Joint motion's always first. It's always first. That's the first motion. Think of two joints, right? Two joints. Here's gross up here. Can I get any movement up here with no movement down here? That's normal. That's normal. This has to be abnormal for that to happen. I'm talking about normal. So can I have any normal up here with this joint and no normal motion down here? I can't, can I? Now this can be fixed, right? It can be fixated or fused, and I can have gross range of motion. Are you with me? But all the range of motion starts at the pivot point. Gross range of motion is not the pivot point. That's the range of motion up here. The next range of motion down here is the overpressure. It all starts at the pivot point, and that's called paraphysiological joint space or joint motion. That's where all motion starts, okay? Unless it's aberrant, unless it's fixated, right? In other words, something's wrong, a fixation. That's what typically you see with joint motion, overpressure, fixations. That's where all the problems are in chiropractic, by the way, too. So, having said that, so it's only 70% is elastic. Only 70% is elastic. 70, okay? So what does that mean to the patient? It means they're going to have more restrictions with their neck, with their back, whatever it is they're going to do. Now, when they heal that way, this is why they have pain, restrictions, limited mobility. This is why they alter their behaviors. This is why it affects ADLs. But it doesn't affect them typically in gross range of motion. It affects them in overpressure motion. So if you're not getting the documentation in overpressure, you'll miss it. Because their active range of motion is typically normal. It's the overpressure motion that is pain sensitive, has a fixation, more sensitive. Some of you guys probably have injuries, old injuries, right? Whether it's an ankle or something. Do you have restrictions in that joint? Do you have pain in that joint? And do you have maybe some normal range of motion, pain and active range of motion? No trouble. But when you try to take it a little bit in overpressure, now you start to feel the restrictions and pain. See? That's what happens. That's what's happening every time there's an inflammation. So what matters is the degree of inflammation. Is it subthreshold or is it threshold? If it's subthreshold, that means it's not affecting the patient's functional capacity in any way. Sensory, neurological, motor. It's not an impairable rating. It's not a compensatable injury. I've got a scar here. It's a scar. Does it affect sensory? No. It's not affecting. Is it affecting motor? No. Is it affecting range of motion? No. But it's a scar. Is this a rateable injury? No. Why? It's not affecting my ADLs. It's not affecting me. No big deal. Okay? So it has to be at least threshold. So it's got to be a threshold injury. Okay? And that's why you have to have the diagnostics to go in there and find those threshold injuries. Because you need to be highly sensitive when you're testing, because the gross stuff, they're long gone. Our low impact injuries do not have gross injuries 2 months and 3 months later. They're long gone. They're normal and back to normal. It's the sensitivity, joint motion. That's where all the problems are. So, relative to this graph, repair proliferation phase, this is absolutely the most important phase of the healing, especially with you as the chiropractor, because this is what naturally happens. And so everything you're trying to do in the inflammation phase is try to decrease pain, inflammation, muscle spasms. Well, everything in the repair phase, that's what you're trying to do. Your therapeutics is trying to decrease nerve sensitivity. It's trying to increase the nerve threshold. It's trying to align the collagen so the neurological fibers don't get mixed in the matrix. It's trying to align the collagen also, so it increases the strength. And it's also, the chiropractic adjustment is also used to increase, or your therapies is used to increase the elasticity, not just in gross range of motion elasticity. That's not going to be the problem. But the passive range of motion and overpressure motion. And what's the only therapy that affects all three ranges of motion? Active, passive, and joint motion. A chiropractic adjustment. And of the three types of therapies, which one has overwhelmingly the greatest effect? Active, passive, or joint motion? Joint motion. Why? Over 80% of the rehabilitation is going to occur in the joint motion. Why? It's the pivot point. It's the pivot point. That's where it all starts. So when you go and do the adjustment, that's where the highest amount of tensile strength is going to occur. You're not going to be thrusting into active range of motion. There's not going to be much tensile strength there at all. You'll be a little bit into the overpressure, but where's the majority of your high velocity, low impact going? Active motion, passive, or joint? Joint. Which leads to the mechanics of chiropractic. How is chiropractic affecting these factors? Okay. Does chiropractic adjustment or any of your therapies affect the increase in the number of nerves? No, I don't know of anything that does. No. Does your chiropractic adjustment affect this? Let's go down each one of these categories now. And let's only talk about chiropractic, okay? Not your other therapies. Does chiropractic affect the nerve threshold? Yes. Oh, yeah. What's the basis of it? The gate theory. You know this is what? You hit your thumb with a hammer, what's the first thing you do? You go to grab it. And as soon as you grab it and you create an extra stimulus, it overrides the pain stimulus and it feels better. That's why you'll grab it, or that's why you'll move it. Like when something hurts or it's numb, you'll try to move it. Well, what are you doing when you move it? You're stimulating what? The mechanoreceptors. And the mechanoreceptors are now acting in the gate theory capacity. That's how chiropractic helps with that. You need to be able to explain this to a jury. Do you understand this? That's how chiropractic helps with, so I'm being real specific with these categories. That's how chiropractic helps with the lower threshold of the nerves. What's the next problem with the nerves? It gets tangled in the collagen. So how does chiropractic help that? Chiropractic, physical medicine, when you apply chiropractic in the line of drive, just like Wolff's Law with bone, how important is the line of drive with force and soft tissue? Just like force is important with bone and creating a matrix and a stronger matrix in one direction where there's more stress. How important is that? Very important. So it's no different with your soft tissue. So when you adjust the patient, what are you doing to that collagen that's in its matrix? You're helping to align the collagen. How are you doing that? Line of drive. Essentially what you're doing with your line of drive in the paraphysiological joint space motion is you're pulling those collagen fibers. And just like those 10 strings that I showed you, if you take them all around and you start pulling them, they all start coming into a line and they start developing the stress line. Now, what is the physiology? What's that called? When you adjust a patient, what's happening? It's mechanical energy that's getting transferred into what? Electrical energy. What stimulates growth? Tissue growth or bone growth in your body? Chemical or electrical? Electrical. So when you adjust a patient, it's mechanical energy being transferred into an electrical stimulus, and the electrical stimulus is propagating the growth and the pulling of the fibers in this direction, this direction, this direction. Just like, if you think about it, like the matrix in your femur that you can see on an x-ray. It has to be in a certain way because there's more weight in this direction. Does the matrix need to be strong in a horizontal direction of your femur? No. And so, where does the matrix naturally grow? It grows where the compressive forces are. Why? Because of the piezoelectric effect. Mechanical energy, in other words, there's more pressure this way that stimulates electrical energy, and it's the electrical that stimulates cellular growth, osteoblast or cellular growth. That's how and why, when you give a chiropractic adjustment, it helps to align the collagen. Now, how often do you need to give that treatment? Once a month? Won't do it. You need a high frequency. You need a high frequency of physical medicine to produce the piezoelectric effect. Once a week won't do it. Twice a week. I told you. A client the other day put a patient on twice a week care right off the bat. I said, you're partly responsible for their permanent injury. You did not. And the example I give is lifting weights. If you want to build weights, what's the bare minimum times a week you need to lift weights? Huh? In other words, you need some frequency, don't you? You need some piezoelectric frequency. By the way, that's what you're doing when you lift weights, right? You're creating a mechanical energy that creates some electrical energy that stimulates the growth, right? That's what's happening when you're lifting weights. Well, that's what's happening when you're adjusting the patient. Mechanical energy going into electrical, but it's going into a line of drive. It's going into a specific direction where the strength needs to occur. Does that make sense? This is what you need to be able to explain, whether it's to an attorney, really to a jury. So that's why chiropractic increases the strength of the tissue, is through the alignment of the collagen, and that's why you need the frequency that you do in the repair phase. The last is elasticity. How does chiropractic increase the elasticity? It's no different than a rubber band. I mean, it's unbelievably simple to explain to a jury. You take a rubber band and you just pull it periodically and keep pulling it, and eventually the rubber band just kind of stretches a little more. It's unbelievably, in other words, the tissue is viscoelastic. Now, we're not talking about ligaments as much as we're talking about connective tissue, because ligaments are not viscoelastic, are they? There's no viscoelastic property in ligaments. So when you get that LMSI, or you get that translation or angulation, is it coming back to normal? It's never coming back to normal, because that's not viscoelastic. Those ligaments are what's holding it together, and they are not viscoelastic. The collagen is. Well, where's the collagen? It's everywhere. It's around the nerves, it's around the tendons, it's around the ligaments. I mean, it's fascia, it's the disc, it's the whole matrix of collagen. I'll show you a picture. So that is what that's why chiropractic helps with the elasticity. And that's why chiropractic is so beneficial with injuries. It helps decrease the pain through the threshold effect. It helps to, through the piezo or the gate theory. It helps to align the collagen, which decreases the entanglement of the number of nerves. That decreases the pain. By increasing the alignment and the piezoelectric effect, it increases the strength. And the natural force increases the elasticity of viscoelastic tissue. And the reason it's so important is it starts with the pivotal point of range of motion. It starts at the joint, in joint motion. From there, then it goes into passive range of motion and active range of motion. That's what you explain to a jury. And that's what I was able to explain to the jury, and why. And I was able to show mechanism of injury, the subjective findings, the hybrid subjective findings, and objective and totally objective. And then I was able to explain, this is why when she bent over, she could move fully, but when she bent over to pick up her 6-year-old kid, this is why it was painful and she couldn't. That's what the jury said. And they saw it. They saw it on the x-rays. They saw the mechanism of injury. They saw the symptoms. And they saw the coordinated findings, the hybrid findings. I put it all together, explained the 3 phases of healing relative to physical medicine. I couldn't help her enough. She eventually healed permanently wrong to some degree. She reached MMI. That led to the permanent impairment rating, and this is why she's going to have problems the rest of her life. And it's the beginning of a pathological process. It alters the biomechanics of the joint. Well, as soon as you alter the biomechanics of the joint, that's called the precursor to osteoarthritis. Osteoarthritis is the #1 disability in the United States. So what does that mean to the patient? Pain with movement? What kind of movement? Activities of daily living. Working, sleeping, bathing, showering, cooking, cleaning, laundry. How important is that to life? That's called life. That's what life is. And so it becomes unbelievably important that this person now has some pain and restrictions in life's activities, and they're guaranteed to get worse. Why? Because it healed permanently wrong. Once it heals permanently wrong, that's it. Once you're through the 3 phases of healing, once you're through the repair, the remodel phase, that's cement. It's done. And now it's permanent. So now you have altered biomechanics because how the joint didn't heal properly with the collagen. So it's not moving normally now. And then let's just take that through the years. It just gets worse and worse and worse. And you as a chiropractor take an x-ray of the patient's neck 5 years later, and what do you see? A big fat spur. And what else do you see? A hugely degenerative disc. And it was from an injury 5 years ago that wasn't compensated, or the insurance gave her $500 not to sue. Sound fair to you? And then how's it typically affecting the patient? Pain, restricted motion, right? What else? Sensory? Maybe typically not. Motor? Yes. They don't have as much strength because of the pain, right? So you got pain, motor, weakness because of the pain, right? Limited mobility with activities of daily living. Pain has come. How does it start affecting, besides the ADLs, how does it start to affect their attitude? You guys have seen patients with depression. How does it affect their relationships? Right? You think this is a minor deal. And you think this is a minor deal. But not one of you will allow me to put you in a car, turn your head, extend it, slam you from behind, give you a whiplash injury with the joints locked out without you paying attention, and let me hit you at 10 miles an hour. None of you would let me do it for if I gave you a $100,000 check. Because you know exactly all the problems, because it's not going to be one and done. By the way, will you take a fracture, a long bone fracture, for $100,000? Every day. How quickly does that long bone heal? 4 to 6 weeks. Any complicating factors if it's in the long bone? None. Every 6 weeks I'll line up for $100,000 and a broken bone. Give me the check. I'll never do it. I'll never do it for a 10 mile per hour with my joints locked out in a whiplash with no defensive mechanism. You can't get me. I'm not going to do it. Because I know the crap I'm going to have the rest of my life because of that. It's just going to keep getting worse. This is the value you're performing. This is the value you should be performing if you're not performing it. Do you understand this? The first value is the who. The patient. Does the patient not deserve to be compensated for that, especially if they're not the victim? Yes, they do. Did they probably pay insurance to be compensated for that? If they paid insurance and it's no fault of their own, should they be reimbursed for a permanent injury the rest of their life that's going to affect their motion, pain, their attitude toward their family members, their kids? Should they be compensated for that? They should be compensated for a policy limit. And that's not even enough. Because they're never going to be the same again. And it's going to get worse. How fast it gets worse depends on how they're treated from that point forward. The only thing we do at that point is palliative care. We just try to slow down the progression of the pathological process and the disease process and the pain and discomfort and all that. That's all we're trying to do. We're just trying to slow it down. Once it's permanent, that's all we're doing. That's the importance of the 3 phases of healing. And that's what everything you do is based on. Your therapeutic protocol in the inflammatory phase, first of all, you should have all the biomarkers for inflammation. Subjective, hybrid subjective and objective, right? And objective. You should be paying a lot more attention to the sensitivity biomarkers. We're going to go more and more into those. Then you should do your inflammatory protocol, right? And quantify it. Because quantifying it's going to tell you what? Are they getting better? Are they getting worse? Is it gone? Do I need to get a second opinion? Or is it now permanent? Isn't that what quantification is going to do? Okay? So we not only want to document it, we want to quantify it for those reasons. Then when they're coming out of the inflammatory phase, we want to start moving them into what therapeutic protocol? The repair phase protocol. What's the core of the repair phase protocol? Active range of motion therapy, passive range of motion, and joint motion. What areas of the anatomy are we going to affect? Hyperinnervation, reinnervation, nerve entanglement in the matrix, the alignment of the collagen, the strength and the elasticity of collagen. That's what's going to happen in big time in the repair phase. Then what happens in the remodel phase? There's no more collagen synthesis. Now we're just looking to increase the strength of the tissue and the elasticity of tissue to decrease the likelihood of re-exacerbations and debilitation. That's your therapeutic protocol for that. Does it make sense? How much common sense does this make?